Hi, Dr. Yates. It's so nice to get to meet you outside of our typical discussion post interaction. I'm really looking forward to your feedback after this. My presentation is going to be presenting on alcohol use disorder, diagnosis, and treatment. My goal for this presentation is really just to provide an overview of how alcohol use disorder, or AUD, which is the acronym I will be using throughout the presentation, is diagnosed, how it affects the brain as well as society, and what evidence based and culturally competent treatments look like in real life settings. So, alcohol use disorder is actually one of the most prevalent and deadly substance use disorders in the world, which tends to surprise people oftentimes. Over 15 million adults in the US alone are affected every year, and it contributes to high mortality and justice involvement. Aside from the statistics, AUD also often overlaps with trauma, impulsivity, as well as systemic barriers, especially in forensic and marginalized populations. In my presentation, I will be briefly going through the DSM-5-TR diagnostic criteria, different assessment tools, and some treatment approaches that are not only evidence-based, but also trauma-informed and culturally competent. According to the DSM-5-TR, alcohol use disorder is defined as a problematic pattern of alcohol use leading to significant impairment or distress. To be diagnosed with AUD, an individual must meet at least two of the listed symptoms within a 12-month period. So these symptoms can include criteria like impaired control, social impairment, risky use, as well as physiological signs such as tolerance and withdrawal. I think that these criteria really help us as clinicians gain a fuller picture so that we're not just looking at how much someone is drinking, but how that drinking is also affecting their relationships, their obligations like work, school, and just their overall functioning. Alcohol use disorder can range from mild to severe, really depending on how much criteria is met. So, for 2 to 3 symptoms, that indicates a mild case, 4 to 5 being moderate, and then 6 or more is considered severe. It's also really important to consider remission and environment. So, for example, someone in a controlled environment like an inpatient setting or incarceration might meet fewer criteria, but they're still struggling with the cravings and other symptoms. These specifiers really do help us as clinicians better understand where a client is in their recovery journey, and as well as their recovery process, and how best to tailor support and interventions as well as treatment approaches. For neurobiology and mechanisms, addiction affects so much, including specific circuits in our brain. So there's a lot that's happening in our brain, and I touch on a little bit of it, but it typically progresses through 3 stages. So binge and intoxication, withdrawal and negative affect, and finally preoccupation and anticipation. The prefrontal cortex, which is responsible for decision making as well as our impulse control, often shows reduced activity in those that struggle with alcohol use disorder. So that helps explain why relapse can happen even after super long periods of sobriety. So essentially, chronic alcohol use does reshape the brain's reward and stress systems, which then reinforces the compulsive drinking despite the harmful consequences that come with it. So I have a little picture right here on the side of the slide on what happens in the brain when alcohol is consumed. So, when we take a look at public health data, alcohol use disorder does remain a major global issue. Alcohol contributes to almost 6% of all deaths worldwide and 5% of the total disease burden. With that being said, these numbers don't tell the full story unless we also consider cultural and socioeconomic factors. For example, individuals from lower socioeconomic backgrounds do tend to face higher risks due to stress, trauma, and systemic barriers like limited access to care. Early detection and culturally responsive interventions are super important when it comes to reducing these disparities. So, for the diverse and forensic population, whenever I'm writing an essay or doing a presentation for any course that I'm taking, I always like to tie it back to my current work, which is with the forensic population. So, this is just connecting it back and making it a little bit more personal. Alcohol use disorder is especially prevalent in the forensic setting, with about 65% of incarcerated individuals meeting diagnostic criteria. So many of these individuals have chronic and severe histories of trauma, including childhood abuse, adverse childhood experiences, exposure to violence, etc., which increases vulnerability. Gender also plays a role. For example, many women experiencing shame and stigma that make it harder to seek help. The so-called wine mom culture, which was super interesting to explore in the article by Hill and Masrick, explained how this wine mom culture even normalizes heavy drinking under the disguise of self-care, which can mask deeper issues of stress and coping, which I found really interesting. So, screening tools are, of course, crucial for identifying alcohol use disorder early. The audit test is one of the most reliable, but tools like CAGE and MAST are also really great for quick assessments. The Audit C focuses specifically on heavy drinking, and the timeline follow back helps track patterns over time. I also wanted to highlight the SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment, which is a model that works really well in both medical as well as community settings. It's important to add that screening tools must be culturally adapted to ensure that clients do feel understood and respected. I strongly believe that clients can feel when clinicians are genuinely interested in their stories, in their culture, in viewing and understanding them within the context of their life and experiences. Um, Clients can always pick up on it. I strongly believe that. Beyond basic screening tools, though, we can also use structured and neurocognitive assessments to understand how alcohol use does affect the brain, since heavy use can impair different things like attention, memory, and our problem solving abilities. So, tools like the Addictions Neuroclinical Assessment looks at things like reward sensitivity, emotional regulation, executive functioning, and these tests not only help with diagnosis, but they also give us further insight into relapse risk as well as treatment planning. So it's really important to remember that culture very, very heavily shapes how people respond to assessment tools, not just assessments, but even our sessions with clients. So, for example, self reports can underestimate drinking due to fear of stigma or legal consequences, especially among forensic clients. I have a lot of clients who oftentimes tell me that they don't feel comfortable being fully honest or transparent, especially during the intake assessment, due to the impact that their answers may have on like court program acceptance, like mental health diversion or mental health court, or them being remanded if they do report substance use or a recent relapse. So that plays a big part in it. Additionally, language barriers, trauma, and then literacy levels can all affect the validity of results as well. I believe that as clinicians, it's our job to choose tools that are not only reliable but that also are accessible for our clients, and interpreting them through a culturally sensitive lens. I think that that's a really big part of social justice and advocacy, which comes along with our role. For cultural competence and ethical considerations, cultural humility also goes way beyond just being aware of diversity. It requires constant reflection on our own biases. Historically, diagnostic frameworks have been grounded in Western norms, which can lead to misdiagnosis or overpathologizing, which is something that our course textbook talks a lot about. I strongly believe that when we approach clients with cultural humility and that curiosity, that we genuinely want to know their experiences and like the context of their life, that we are better able to validate their lived experiences and build that rapport, reduce the harm through creating a safe space. that space of safety as well as acceptance. So this is especially crucial in forensic practice where cultural misunderstandings can directly impact legal related outcomes. So a lot more at stake. As for evidence based interventions, there are many interventions, well, not many, but there are multiple interventions that are proven to work with alcohol use disorder. Motivational interviewing being one, which helps with enhancing readiness for change, even in mandated settings. This is highly encouraged where I work. Cognitive behavioral therapy also addresses distorted thinking patterns and helps clients manage their triggers. We also have mindfulness based relapse prevention, which helps reduce those automatic responses as well as cravings. And then pharmacological options like naltrexone and disulfiram can all, I'm not sure if I'm saying that right, but can also greatly support recovery. For example, many of my clients are on Suboxone, which has been a huge help alongside therapy for them, just with helping with the cravings, temptations, and feelings of wanting to relapse. Uh, Additionally, and really importantly, is just integrating trauma informed care, which is essential. I would argue that it's essential all the time, but especially for justice involved individuals. So, for personal impressions, overall, after having read so many articles and done the research, alcohol use disorder really does need to be viewed through a biopsychosocial lens, because it's not just biological or a psychological issue, it's a mix of both. And viewing that within the person's social and cultural context. As a current forensic mental health clinician, I think that it's really important that we're able to balance empathy with accountability, and just understanding that healing often does happen alongside not just support, but also structure. So, effective treatment means addressing both the neurobiology of addiction and the environment that continues to sustain it, which is why I love working with the treatment team so much, because when something comes up and it's maybe a little bit out of my scope of practice, I can be like, hey, let me grab the psychiatrist or let me grab the nurse. And then we're all able to collaborate and really come through for the client. So, personally, I just think that the most important takeaway is just to always see the human beyond the diagnosis. Every person's story of addiction is really shaped by their experiences, their culture, their trauma, pain. And as clinicians, our role isn't just to treat symptoms, but to create that space of safety for our clients, to reduce stigma, and really walk alongside them in their recovery and healing journeys. So that is it for my presentation. Thank you so much for listening. I hope that it did provide a comprehensive overview of alcohol use disorder, from diagnosis and assessment, also to treatment and cultural context as well. So I really appreciate your time, and I look forward to hearing your feedback. Sorry, I get a little stuttered sometimes when presenting. I have my reference page here. um, I could not figure out how to get hanging indentation on the presentation side. So I also just attached a picture of my reference list, which was in my Word document. But both of them provide the DOIs on there as well, which will link you directly over to the articles that I found. But yeah, that is it. Thank you so much again, Dr. Yates, and I really look forward to your feedback. Have a good night.